is Maria Grigg, and I want to talk a little bit about administering anesthesia in the elderly, the risks, benefits, pharmacodynamics to keep in mind, and which anesthetics we definitely want to stay away from. But first, why do we care? For instance, how often do we even do surgery in the elderly? So to start, I want to try to describe the burden on this population. In 2014, about 1 in 7 Americans was over the age of 65. Globally, this makes up about 10% of the world's population. And by 2050, this number is projected to double, which will be about 1 in 4 Americans. The question remains, will these folks ever see the inside of an OR? In 2008, the Anesthesia Society created a database that pooled reports from thousands of private and academic hospitals across the country, including both ambulatory and inpatient procedures. In the next few slides, I'm going to present findings from this dataset. Now, this table shows the total number of surgeries performed in each age group. While there is a decreasing trend in the number of procedures with age, we can see that the 65 and over population undergoes about a third of all surgeries in the country. For those young, sprightly late 60s folks, ophtho procedures are by far the most common. Also notice that 5 of the 10 surgeries were ortho-spine. This is significant because orthopedic surgery tends to allow a wider range of anesthetic options, such as regional blocks. Once we hop on over to the next decade, we see that the list remains largely the same, particularly the top 5. However, we stop doing major heart surgery and instead do more uro and colon resections. For folks in their 80s, the picture doesn't change much. There's a bit of rearrangement of the ranks, and the fairly invasive and morbid hip replacements have given way to the simpler repairs. Now, morbidity and mortality. This table shows the percent of all surgical cases within an age group that resulted in a major adverse outcome. At first glance, the percentages seem small across the board, and that's a testament to how good we've become at perioperative management. But let's compare the first column to the last, which shows the percentages from all patients over 65. We can see that on average, geriatric patients are between 5 and 6 times more likely to experience major perioperative complications, including death. To summarize these findings, the elderly make up 14% of America's population, but undergo a third of all surgeries in the country, and this number continues to rise. Procedures that are most common are ophtho and ortho. And finally, these patients have significantly more adverse complications than younger people. So is that just an inevitable part of aging, or can we do better? Before we talk about specific pharmacologic strategies, let's delve into geriatric physiology. In the cardiovascular system, atherosclerosis and collagen deposition lead to an overall reduction in arterial compliance. Over time, the increased pressures cause chronically elevated systemic vascular resistance, leading to ventricular hypertrophy. This has a variety of deleterious consequences. First, increased pressures from the ventricles transmit to the atria, causing dilatation. This can predispose to arrhythmias, and in fact, the incidence of supraventricular tachycardias increases with age for both men and women. Moreover, hypertrophy worsens diastolic relaxation of the ventricles, which can exacerbate coronary perfusion and manifest as perioperative ischemia. Poor relaxation also results in a lower end diastolic volume, which is one of the main contributors to a drop in cardiac output. Another contributor is gradual onset of interstitial fibrosis. The resulting myocyte dysfunction leads to a desensitization to beta-adrenergic receptors, which impairs the heart's main mechanisms of responding to hypotension, contractility, and heart rate. As a result, the geriatric patient must rely on adequate preload and vasoconstriction to maintain blood pressure. Within the lung, increased collagen deposition and lost valvular tissue lead to a drop in elastic recoil. Meanwhile, degenerative changes in bone and muscle result in chest wall rigidity. Together, these contribute to extensive alveolar collapse, manifesting similarly to emphysema. One of the sequelae is a change in pulmonary function, particularly a rise in residual volume and a drop in vital capacity. A loss of the alveolar capillary interface results in decreased diffusion capacity, causing substantial VQ mismatch. Under anesthesia, these effects are more pronounced and can rapidly progress to hypoxia and hypercapnia. A collapse of peripheral airways impairs our main cough and swallow reflexes, which puts the post-op patient at risk for aspiration as well as pneumonia. In the hepatorenal domain, an overall drop in cardiac output means a decrease in both hepatic and renal splanchnic flow. Let's first focus on the liver. Less blood flow leads to a drop in the overall mass and replacement of hepatocytes with fatty fibrosis. As a result, hepatocytes cannot make adequate amounts of vital proteins like albumin. In addition, there is an impaired function of enzymes like cytochrome P450, resulting in a decrease of first-pass metabolism. On the renal side, a decreased perfusion leads to major drops in GFR and subsequent atrophy of the nephrons. In fact, we lose up to half our glomeruli by age 80. The most pronounced effect is a delayed metabolism of renally excreted drugs. In addition, the tubules become desensitized to hormones like ADH and aldosterone, resulting in dehydration, electrolyte imbalance, and inability to concentrate urine. Finally, let's take a look at the central nervous system. Reduced gray matter volume results in cerebral atrophy. By age 76, we have lost about 30% of our total brain mass. One important consequence is difficulty regulating temperature, predisposing to hypothermia and its harmful downstream effects. Less brain mass also signifies a smaller requirement of all anesthetics. And this brings us to the concept of MAC, or minimum alveolar concentration. In simple terms, MAC is a measure of potency. The lower the MAC, the less of the drug we need to be anesthetized. As you can see from this graph, which shows the potencies for 3 most common inhalation agents, MAC decreases with age across the board. A loss of brain tissue also leads to a decreased synthesis of neurotransmitters, predisposing to cognitive deficits both pre- and post-op. Consider the capacity of your patient when asking to sign consent forms. Finally, both cerebral atrophy and the drop in cardiac output contribute to a decrease in cerebral blood flow. The elderly patient thus has less reserve to handle intraoperative periods of hypoxia. Let's finish our discussion with specific strategies and concerns for the intraoperative management. The high prevalence of ophthalmic and orthopedic procedures in this population allows the opportunity to use regional anesthesia, which is defined as administering local anesthetics into perineural spaces for a temporary blockade. There's a variety of benefits to a regional-only approach, such as improved hemodynamics and less immediate complications. It also allows for a quick and accurate post-op assessment. It's not surprising, then, that providers are increasingly turning to regional techniques, shown here in red, in place of general anesthesia, shown in blue, as their patients age. Despite these findings, studies have shown there is no significant difference between the two techniques in 30-day mortality, post-op cognitive function, or incidence of delirium. Moreover, there are significant challenges to administering local anesthetics in the elderly. The sympathectomy produced by spinal anesthesia may result in profound hypotension. Access to the vertebra or muscular structures may be very difficult in the context of scoliosis. And the duration and local spread of the block is a lot more difficult to predict in this population than in the young. For these reasons, there is no one right choice of anesthetic technique for a given surgery, and risks and benefits of each must be weighed on a case-by-case basis. I want to briefly touch upon special considerations of 3 common agents. The general theme of administering any drug to these patients is care, vigilance, and patience before giving a higher dose. Let's first look at propofol. Propofol is a GABA agonist that is commonly used for sedation. It can be utilized on both induction of anesthesia as well as maintenance during the entire surgery. It generally has a very short half-life. However, the proportion of adipose tissue increases significantly with age, increasing the volume of distribution of these lipophilic drugs by orders of magnitude. As such, initial dose reduction and slow titration are essential. Propofol can also cause a significant drop in systemic vascular resistance and subsequent hypotension, which may not be ideal for patients with cardiac instability. Etomidate is another common sedative that is also a GABA agonist, though with a slightly different structure. Like propofol, it can be used on induction or maintenance. But unlike propofol, it is very cardiostable, making it a good choice in patients who depend on afterload, like in cases of aortic stenosis. The main side effect of etomidate is adrenal suppression, which must be of special concern in the elderly population who frequently already have end organ damage. Volatile anesthetics are used for maintenance anesthesia. When selecting a starting partial pressure, it's important to remember that MAC is additive. That is, if the patient has already received other drugs, they'll require even less of the gas than the calculated MAC. Volatiles also run the risk of postoperative nausea, vomiting, severe hypotension, and prolonged emergence. I want to finish this talk with a few additional but important concerns. Along with the already impaired thermoregulation center, the elderly experience significantly more intraoperative heat loss, which lowers their anesthetic requirement even further. Prevention strategies include keeping the area under the drapes warm with a bare hugger, using fluid warmers, and ensuring that gases are set to a low flow rate. Special care must also be given to positioning. An emaciated patient with no fat pads runs the risk of nerve compression, while an obese patient in Trendelenburg can suffer lung compression from the cephalad displacement of the diaphragm. Due to bone fragility, sudden movements may result in serious injury, and we must always be vigilant about pressure ulcers during long cases. I hope this has provided some fundamental tools for the management of the geriatric patient. As our population continues to age, these skills will become more integral in our daily practice. Thank you.